Yeah, that will help me because I have a bad throat. So sorry about it, first of all. So I guess like everybody from morning was loaded with information, and now it's my turn to load you with much more information. Mm. So it's basically uveitis as a whole topic. So I wasn't very sure like how to cover it because it is not something very specific about one topic in uveitis. So I've tried to concentrate more on anterior uveitis because it is post-graduation and that's what you might get in exams. And then probably like some amount of gist in posterior and intermediate. It's okay, no? Voice, you're able to manage? Okay. So uveitis, you have like anterior, posterior, intermediate, pan-uveitis. So when you see something like this, no, we really start scratching our head. Like, what do you do when you see something like this? Okay, what should you do when you see a patient with uveitis? You do these tests, you do all these investigations and all that. So any patient with uveitis, so first of all, you see whether it is uveitic or non-uveitic. Okay. If it is, because there can be a lot of other things which can mimic uveitis. Okay. So if it is uveitic, which part of the uvea is involved? I mean anterior, intermediate, posterior, and what is the stage of the disease? Once you are very sure that it is uveitic, then you decide whether the cause is whether infective or non-infective, and how to manage or prevent recurrences. Because there are a lot of conditions mimicking uveitis. Okay. So conjunctivitis, patient can have some pain, redness, even in foreign body sensation, they can complain as pain. Angle closure glaucoma. Central serous retinopathy can have subretinal yellow spaces. Masquerade, ARM changes and others. So how do you say whether it is uveitic or non-uveitic? You try to first find out about the inflammatory signs in uveitis. And which part of the uvea is involved? Let's start up of a case of a anterior uveitis. So if you think it's anterior uveitis, first of all, see, is it anterior uveitis surely? Or is it anterior uveitis only? Because if it's anterior uveitis surely or not, you'll see based on what are the other conditions. If it's anterior uveitis only, because it can be part of a pan-uveitis or part of a intermediate uveitis with spillover anterior uveitis. There can be cornea, sclera and other parts involved. Whether it's ocular alone or part of another systemic disease, okay, or uveitis at all. So now you found anterior uveitis, okay. The next set will be to decide whether it is active or inactive. Then you see whether it's mild or severe. How do you decide about this? Based on Sun Working Group classification. Severity and activity based on either investigations or Sun Working Group classification, you will have to grade it. Then you decide about granulomatous and non-granulomatous. You might be answering hell a lot of high-five latest journals questions, but if you don't answer basic Sun Working Group classification or AC grade, AC reaction grading and AC flare vitreous grading or granulomatous, non-granulomatous differences in exams, then we presume that you don't know basics of uveitis. Okay, so even if you don't know other things, okay, there are some problems with people coming out with big tertiary eye care centers who might answer the latest SSOCTA, white spaces and so many things, but you may not be able to answer granulomatous and non-granulomatous. So that's most important, that you know the basic things very surely and then go on to the next step. So you need to know the grading of uveitis, then granulomatous and non-granulomatous, type of KPs, whether fine, stellate, scattered, medium-sized, mutton fat, and whether it's associated with raised IOP or not, and most importantly, hypopyon. Okay, we'll try to see one of thing. This is a 32-year-old male who came with pain, redness, and diminished vision. Okay, so what is this? What do you see here is a slit picture. Fibrinous membrane. So in a patient who comes with fibrinous anterior uveitis, so what do you ask for? Joint pain, then skin lesions, very good, then history of backache, skin lesions and other things. So if you have a patient who has a fibrinous anterior uveitis with history of backache, then you ask for one test. Which test? HLA-B27. Okay. This patient, see, a cardinal rule in any uveitic condition is, if you are allowed to do one test, which one you'll do? Okay, order that as the first test. I mean, you should always think that you're not allowed to do packages, vasculitis package or uveitis package and so many things. If you're allowed to do one test, which you'll do. So that will be the first DD. Okay. Do not order tests like, see, if you want to order CRP. I don't think anybody bases anybody's treatment based on CRP. So I see hell a lot of packages having CRP. So don't order test on which you will not plan your management. Okay. So this patient was HLA-B27 positive. So what do? You start with topical steroids and cycloplegics. Intense topical steroids, prednisolone acetate is commonly we use because acetate enters very well. Prednisolone is a good steroid. With cycloplegics, atropine probably initially, and then later on change over to homotropin. And 1 week post-treatment, the fibrin broke up and Seneca broke up. So it started retracting fibrin. So this means that it is showing response. So any non-granulomatous fibrinous anterior uveitis, you ask for history of backache, joint pain, skin lesions. You look for the posture of the patient, look for any of the investigations, and do HLA-B27 testing. So what are the causes for HLA-B27 associated uveitis? Retest, ankylosing, psoriatic, and inflammatory bowel disease related. Okay. The mnemonic was by chance. So topical steroids and cycloplegics. When do you use systemic steroids or immunomodulators in patients with anterior uveitis? If there is associated ankylosing spondylitis or GRA associated diseases in chronic anterior uveitis, even in anterior uveitis, you can use immunomodulator therapy. Okay, another one. This is a young patient, painless diminished vision. What is this? So pus anywhere in the body, you will have to remove it, except in the eye, which you can treat it medically. Okay. So ask for what? Very good. After genital ulcers. Then look for, see if there is vitritis, vasculitis, FFA. Do the FFA. If FFA is showing some good pictures, then test for B51. So which disease we are talking about? Okay. So tell again. But this has a thick hypopyon with convex upper border. So you look at the hypopyon also. So what kind of hypopyon is more important? So the moment you see hypopyon doesn't mean that you'll ask for after genital ulcers, because this is a uveitis specialist talking. So it has to be uveitis. But like sometimes hypopyon always should scare you. There's an immunocompetent who had UTI with fever. Had a yellow glow. See the glow like this. A yellow glow, fluffy, organizing. Fundus showed clumps. It's actually endophthalmitis. Okay. So remember that if hypopyon, think infection first, not uveitis. Okay. So Behçet's is common in AIMS, RP Center, LVP, Shankarnathali, Arvind, but it's not a common disease otherwise in India. Okay. So if it is hypopyon, then you do think of infection, rule out, and then think of inflammatory causes. So hypopyon uveitis, if it is an organized fibrin, organized coagulum, it can be HLA-B27 associated uveitis. If it's a transient mobile white hypopyon, it is Behçet's. But in extremes of age group, in hypopyon, in either in a child or an elderly, think of malignancy or infection, masquerade. So extremes of age, uveitis doesn't come commonly. So hypopyon is never seen in granulomatous. We are all talking about non-granulomatous condition. So but remember that there is no place for terms like never, always, and all that in medicine. So we'll change it. Hypopyon almost never occurs in granulomatous. Okay. So what do we find in granulomatous? This is a 34-year-old male. So what are the findings? Come again. Mutton fat KPs, then checklist again. See if it is anterior uveitis surely. Okay. See whether it is part of intermediate or pan-uveitis, ocular alone and other systemic disease. See active. So this is as granulomatous, mutton fat KPs, and iris nodules. There are a few things in granulomatous. Granulomatous is something that can be associated with systemic diseases. Okay. Tuberculosis and sarcoid are two things that are commonly seen in granulomatous. Okay. If you have a broad-based Seneca, iris nodules, and this patient had a primary complex or multiple recurrences, then you lean towards tuberculosis. If you have a MAN2 negativity, if you have a candle wax drippings in the fundus and other things, you lean towards sarcoid. Okay. So the common two differential diagnoses in a granulomatous uveitis is tuberculosis and sarcoid. In a fibrinous non-granulomatous uveitis, it is HLA-B27. Tuberculosis and sarcoid can present as non-granulomatous. HLA-P27 never presents as granulomatous. Okay. So investigations is a must. So in this patient also had CRA adjacent to a vessel. So these are indicators of probably a tuberculous etiology. Investigate for the same and treat. Okay. Somebody was trying to take a picture, I moved it. Okay. So if you have a granulomatous uveitis, look for broad-based synechia, iris nodules, and fundus pictures. Ask for headache, weight loss, appetite loss. Why headache? Which granulomatous uveitis can have headache? Too much. I'd rather sit there, I guess. So there can be granulomatous conditions where it can be TB or sarcoid or other things also. So TB, sarcoid, VKH, sympathetic ophthalmia, lens-induced. So we would like you to enlist things when you're answering your exams. Either the common ones. So again, come. It's gone. Can you hear? So active or inactive, granulomatous, non-granulomatous. More importantly, the way the KPs are distributed, that is again very important. Look at this. There is another thing when they keep all examiners keep asking you, uveitis in a white eye. Okay, so which are the uveitic conditions in a white eye? Fuchs, in GIA, then if you have uveitis in a white eye with raised IOP, IOP raised in uveitis can be secondary due to synechia, angle closure, steroids, but there can be primary rise in IOP at presentation with uveitis. There are very few conditions where you have uveitis with raised IOP at presentation. Most important is Fuchs. Okay, Fuchs has a very typical scattered KPs, which are not very, very characteristic, not seen in other uveitic conditions. Fuchs is the only not granulomatous condition where you can have iris nodules. Okay, so it's a unilateral uveitic condition in a young adult with heterochromia, polymorphous scattered stellate KPs, glaucoma, absent synechia, then it's Fuchs. If you have recurrent open angles corneal edema, then PSS. There is a third one that can have scattered KPs. So with raised IOP, if you have a sectoral iris atrophy, these are heterochromia all around. If you have a sectoral iris atrophy, then you are dealing with viral. Okay. Others for completion, post-op inflammation, you can have anterior uveitis. This is herpes zoster ophthalmicus. Any young adult with herpes zoster ophthalmicus, you should rule out immunocompromised state. Okay, so rule out HIV testing. So in herpes zoster ophthalmicus in young adult, rule out HIV. This is post-op. In GRA, you can have chronic anterior uveitis with BSK, caterpillar, hairworms, and HIV-associated uveitis. This was what we see in front in slit lamp. But it's always more interesting when you look behind. No? Things are always interesting some behind. So choroiditis and retinitis and whatnot. So what is this? What appearance is this? Headlight in the fog appearance. Okay. So toxo. So is it so easy always in posterior uveitis? Okay. So in posterior uveitis, we have, is it infective or not infective? That's the biggest thing in life. I mean, like you roll it whether infective or not infective, then sky is the limit. We have steroids, immunosuppressants, biologicals and whatnot, like everything. But the biggest difficulty is whether to see whether it is infective or not infective. Whether the disc involved is, whether the disc is involved or not and due to what. Whether there is retinal detachment, subretinal fluid pockets, and whether there are masquerade. The most important point is the retinal blood vessel and its relation to the lesion. Okay, this is the crucial point in everything. So these are my most favorite slides. You know these old movies, when you keep seeing the roll again, there will be a lot of scratches, no, in the thing. Like that, probably these slides of mine will have a lot of scratches. I've used them so many times. Okay, but the thing is, I still like them. So the most important thing is whether the retinal blood vessel is seen clearly or not. If it's seen very clearly, then it's subretinal. It's choroidal. If it's not seen at all, then it is retinitis. If it's partly seen and partly not seen, it is retinochoroiditis. Okay. To repeat, if it's seen very well, it's choroiditis. If it's not seen at all, it is retinitis. If it's partly seen, partly not seen, retinochoroiditis. This you'll have to be very sure about it. Why? Because the major infective conditions fit into this. A focal retinochoroiditis is always toxoplasmosis, almost always. A retinitis is always viral. The second DD can be toxo, syphilis and other things. Choroiditis can be inflammatory or infective. Retinitis or retinochoroiditis is never non-infective. In other words, retinitis and retinochoroiditis are always infective. Okay. So retinitis is viral. Viral is never choroidal. TB is never retinal. Confused? Viral is always retinitis. Okay, it doesn't cause subretinal. Okay. Tuberculosis is mostly choroiditis. Okay. Toxo is retinitis or retinochoroiditis. Okay. So retinitis and retinochoroiditis are always infective. Choroiditis can be infective or inflammatory because we have something called white dot syndromes which are choroiditis. Okay. If you are choroiditis, maybe you should think of inflammatory conditions. But if it is retinitis or retinochoroiditis, you are very sure that it is infective. Except in Behçet's, where you can have retinitis. Okay. Okay. That is for practical sake. Otherwise, this is what it is. Otherwise, then you have granuloma. So if you know this, then major infective conditions are over. So if you have retinitis, suspect viral. When you have prodromal symptoms, history of viral fever. So this is the coalesced in the periphery and treat with antivirals and steroids. See, this is the typical ARN. Peripheral coalesced necrotizing retinitis. You need to know the triad, moderate to severe vitritis. We have so many books, and I somehow love this Kansky. Everything is there in that. I mean, so many times you would have read it before exams, and then you name it. When you become specialist, you realize the worth of it more. So it had told us everything before, and then you treat in immunocompetent edescene. This is one thing that they might ask in exams. The difference between CMV retinitis, PORN, ARN. One is an immunocompetent, one is an immunocompromised, one has vitritis, one is in the periphery, and all that. So read about it. So this is typical ARN treated with acyclovir or valsiclovir. This is CMV retinitis and immunocompromised, and this is PORN, cracked mud appearance. So focal retinochoroiditis is toxo. A congenital toxoplasmosis you don't need to treat. This is reactivation, and this is the typical focal active, headlight in the fog appearance. We treat with sulfonamide and a non-sulfonamide. Pyrimethamine is the best choice, but sometimes you can use clindamycin and cotrimoxazole as a combination with steroids, something called triple therapy. Intravitreal clindamycin is also a good option. Toxo always is not so straightforward. See, sometimes you might get this, something like this. This is called chirales arteriolitis. So if you have a active lesion with overlying vitritis, with chirales arteriolitis, you lean towards toxo. In an atypical necrotizing retinitis, if you have focal lesion with chirales arteriolitis with vitritis, then do not miss these signs. So infective posterior uveitis, you have toxo, tuberculosis, trypanemia and toxocariasis, and the viruses. So choroiditis, I said, can be tuberculous. The other thing is the white dot syndromes. Once it is white dot syndromes, then they have a definite pattern, and you can treat with anti-inflammatory therapy. So we saw whether infective or not infective. The disc involvement can be either disc involvement alone, or with retinitis, or with subretinal fluid or exudative RD. So disc alone can be because of a granuloma. With retinitis can be neuroretinitis. But one with subretinal fluid or exudative RD is something like this. This is a 32-year-old female with sudden loss in vision. Right eye, AC was quiet with weird cells. What could it be? Disc edema with subretinal fluid pockets. So the first DD is probably VKH. You ask for headache. Why this pain on eye movements? For which disease? Posterior scleritis. I want only PGs to answer, not like Uveitis specialist to be answering. So when you have something like this, do FFA. So every time posterior uveitis, you can't diagnose only clinically. So you have infective, not infective based on the retinal blood vessel. So life is not always so easy. Sometimes you need investigations, rather many times. So if you have a patient with disc edema or subretinal fluid pockets, you ask for headache, pain on eye movements, do FFA. FFA, if it shows, this is a typical starry sky pattern. Pinpoint hyperfluorescence with late pooling. So the DD is Harada's, posterior scleritis, or some sympathetic ophthalmia. What is this? Yeah, how do you differentiate each? If you have more ILM folds, pain on eye movements or brow pain, and if ultrasound shows T sign, then it is posterior scleritis. If it is unilateral, I'm talking about all unilateral condition, when it is only posterior presentation. If the other eye has an injury, then it is sympathetic. Or if you have progressively like sunset glow and other things, maybe you're dealing with weak age. But one thing you remember is, this is an active phase, sunset glow comes in convalescent phase. Okay. So bilateral disc edema with subretinal fluids, first DD is Harada's. The next one, if it is unilateral, then probably posterior scleritis, rarely bilateral posterior scleritis. Sympathetic ophthalmia, somehow I like this slide, like it's like Sati system, no? Like when one husband dies, wife also dies. Like, so one eye goes, the other one also goes away. So FFA is very important, the starry sky pattern. The other one which you, the nearest one, non-uveitic condition which mimics that is multifocal CSR. This also has yellow. There's something something dullish, not so yellowish in between that. If you see like that, then it is probably multifocal CSR. The important thing is to look for vitreous cells. Ultrasound, choroidal thickness or T sign, if it is found, then you are dealing with inflammatory condition. If you don't find all this, and if you don't have it cells, and if the patient has history of steroid intake or otherwise, hypertension, stress, then it is multifocal CSR. So remember that bilateral granulomatous panuveitis with exudative is weak age, other eye traumas, sympathetic ophthalmia. Commonest initial manifestation of weak age is Harada's. Presentation of weak age can be asymmetrical, so unilateral weak age has to be differentiated from posterior scleritis, and CSR is the nearest DD which will have to be worried. So if you have a panuveitis with vasculitis, think of Behçet's or tuberculosis. If you have a panuveitis with choroiditis or retinitis, then you think of viral or ERN. If you have a panuveitis with Hypopyon, infective or Behçet's, if you have a panuveitis with exudative RD, then it's weak age or sympathetic ophthalmia. But what if it's neither of that? Then it's intermediate uveitis. You know, we are uveitis specialists are like intermediate uveitis. No, we are neither there nor here, or something like Trishanku. So I keep thinking this. We are neither anterior segment or posterior segment people. So if you find any of this, vitreous exudates, cystoid macular edema and all that, you deal with, you are dealing with a patient of intermediate uveitis. And always remember, beware of imitations. Think of infections or masquerade. Basically, CNS imaging sometimes is required for multiple sclerosis or lymphoma. So, to summarize, any patient with uveitis, you see whether it is uveitic or non-uveitic. If it's uveitic, which part is involved, infective or inflammatory, and how to manage. Anterior uveitis, you go through all the checklist. See if it is active, mild or severe, which type of anterior uveitis. And if it is posterior uveitis, see if it is retinitis or choroiditis or retinochoroiditis. And panuveitis, which group does it belong to? So this never changes. No? Thorough history, good rapport with patients, history. So, you know, that's what experience is the name people say for when everyone gives to their mistakes. Huh? So relevant lab investigations are important. You have so many tests like OCT, OAC. I thought probably something like that will come later on. If at all one thing we want to be worried, I mean, if you're concerned about in uveitic, probably PCR is one thing that is very unique in ours. So intraocular specimen evaluation. Management of non-infective uveitis, vision-threatening lesions, IV methylprednisolone, oral steroids. After that, if it's not recurrent, there's something called primary immunosuppressive therapy that you need to know. In weak age, sympathetic ophthalmia, Behçet's, JRA, and HLA-B27 recurrent. In all these 4 or 5, you need primary immunosuppressive therapy. Otherwise, you give it when it is steroid intolerant or steroid sparing, or when there is recurrence. And if it doesn't respond to this, biologicals. In India, you'll have to be careful about biologicals because of TB reactivation and other things. If there are 2 diseases, you'll have to be thinking of giving biologicals, then probably it is JRA and Behçet's. Infective uveitis, the primary treatment is specific anti-infective therapy along with systemic steroids. Systemic steroids need to be initiated 48 to 72 hours after start of anti-infective therapy. Stop at least 1 week before that. Importantly, advise the patient correctly. Copy it from WhatsApp. Huh? So if in the last few years you haven't discarded a major opinion recovered in you and check your pulse, they said like you may be dead. So change is the only constant. So if you have recurrence, then reevaluate, take another opinion, act fast, assure the patient, think of local therapy, patient is not tolerating, still it's not happening, like escape. No politics, sir. Thank you.